Hello, I'm Dr. Terry Gernsheimer. I'm a professor of medicine and hematology at the University of Washington in Seattle in the beautiful Pacific Northwestern United States. This is our beautiful city and mountain. I want to thank the ITP Support Association for the invitation to speak about treating ITP with mycophenolate, and I'll refer to mycophenolate as MMF frequently. I have to note first that MMF is not an approved treatment for ITP, nor are some of the other medications I'll be discussing. And these are my disclosures. For many years, our understanding was that antibodies were the sole cause of ITP, coating platelets and leading to destruction of platelets in the blood by spleen and cells called macrophages. Here you can see in the white arrow a platelet that's been engulfed by a macrophage, another one being pointed to by the black arrow that has now getting surrounded by a macrophage due to its being coated by antibody. These antibodies are produced by a type of lymphocytes, B cells, and decreasing antibody production, or how well those antibodies work, are very important ways to treat ITP, for example, using rituximab by decreasing numbers of B cells. About 40 years ago, we began to understand that these antibodies also attack megakaryocytes, which are the bone marrow cells that make platelets, and that production of platelets in ITP is also impaired. And the TPO receptor agonists target this impaired production. Another type of lymphocyte, T cells, also turn out to be very important in the mechanism of ITP. Studies have shown that T cells from patients with active ITP, those shown here in this orange color, can actually destroy platelets in a culture. But when ITP is in remission, shown here in these green dots, those T cells act more like the T cells from control individuals in these red dots. And these T killer cells can also directly attack megakaryocytes, so it can affect both destruction of platelets and, again, production of platelets. We also know that there are different subpopulations of the T cells, and that some T cells actually help to regulate the inflammatory response. These are called Tregs. And when the Tregs increase in activity, the platelet count goes up because they're better regulating the immune response and suppressing the autoimmunity, if you will. So a more complete picture of ITP is that antibodies that are made by B cells cause platelet destruction and also affect the bone marrow, but also that T cells can directly destroy platelets and megakaryocytes, but are also responsible for a regulatory function on the other components of the immune system. Mycophenolate is a powerful inhibitor of cell turnover, but especially lymphocyte proliferation, both B and T cells. It also can inactivate the T cell response to inflammation and can cause the death of activated T cells. MMF has been used since the early 1990s for prevention of acute rejection of liver, cardiac, and kidney transplants because both B cells and antibody formation and a direct T cell killing of the transplanted tissues can be important in rejection. Some of the patients who were receiving liver transplant also had a history of autoimmune hepatitis, and it was observed that this also came under control with the MMF. And so the principle of inhibiting both T and B cells was applied to other severe autoimmune disease. And it's been reported to have activity in the treatment of lupus, autoimmune kidney disease, and autoimmune hemolytic anemia when other treatments have failed. There's a very long list of potential side effects that need to be reviewed before starting mycophenolate treatment, including heart, liver, skin, others. But the main side effect that can make it intolerable is gastrointestinal discomfort, specifically diarrhea. And although this usually gets better over time, even without a change in dose, some patients will just not tolerate it. Because it inhibits cell division and production of new cells, especially in the bone marrow, it can lower blood counts, especially platelets. And we see this fairly commonly when MMF is used to treat transplants. So it may seem like a bad idea to treat ITP with MMF, but there is a bigger effect on the immune system, and if it works, the platelet count comes up. Mycophenolate is a powerful immunosuppressive drug, and with that comes an increased risk of malignancy, but especially a significant increased risk of infection. And we'll talk more about that in a few minutes. But I also want to make note that mycophenolate should not be given to pregnant women, women who are trying to become pregnant, or women of childbearing age who are not using proper birth control. The first patient I ever treated with mycophenolate was a 42-year-old engineer. He had been healthy all his life until February of 2000, and at that time he developed nosebleeds and bruising. His platelet count at that time was 10,000, and a bone marrow examination, which was commonly done back then, was also normal. He did respond to IVIG and prednisone, but they could not get him off prednisone without his platelet count falling and him starting to bleed again. His disease got worse, and after getting very high doses of steroids, he developed something called acute hip necrosis, which is sometimes seen with high dose or prolonged steroid use. This shows what this can look like. The black arrows are showing narrowing of the hip space, of the joint space. The white arrows are showing the fracture in what we call the head of the femur here. And you can imagine how very painful this actually was for him. He had quite a limp. He was treated with rituximab, and he did respond with a platelet count that increased to more than 100,000, but his count fell again after 2 years, and he didn't respond a second time. And then he was treated with cyclosporin, a drug that's commonly used to treat graft versus host disease in bone marrow transplant patients and rejection in kidney transplants. And it also can inhibit T cells. After 3 years on cyclosporin, he moved to Seattle, and I met him for the first time. And he responded to the cyclosporin at this point with a platelet count of greater than 300,000. When he saw me, I was concerned that he had been on cyclosporin for such a long time and that it was potentially affecting his kidneys, the risk of infections. So I suggested to him seeing how he would tolerate tapering the dose. Within 3 weeks of tapering his cyclosporin, his platelet count fell to below 5,000. And then despite increasing the dose to the previous level, his platelet count did not increase. At that time, we did not have TPO receptor agonists, but I did try multiple other treatments, including IVIG, rituximab, cyclophosphamide, steroids, but his platelet count did not increase. He had clear evidence of bleeding with blisters in his mouth, bruising, petechiae on his legs, hands, and face, and I was becoming frantic. He was quite stoic and began to refuse any treatment with IVIG or steroids because he felt it just didn't help. At that point, we began treatment with mycophenolate, starting a bit slowly, but increasing to 1 gram twice daily over a month. And within a month of that, his platelet count began to increase and remained above 300,000 for almost 2 years. At that point, I suggested to him that perhaps we should try tapering off the drug. And actually, very nicely, he didn't tell me that I was crazy and walk out of my office. He thought that maybe this was a good idea, and he agreed to try, despite remembering what happened the last time when he stopped the cyclosporin. When he left Seattle 5 years later to move back to the East Coast, his platelet count was greater than 300,000. And he just wrote me last month when he moved back to Seattle, and he is still in remission 8 years after starting the drug off all treatment. This is a visual of his course to just show how dramatic his response was. Here's where we stopped with cyclophosphamide. His platelet counts, cyclosporin, his platelet count fell rather rapidly. Restarting it did not help. IVIG and steroids would give him short bumps. He got a course of rituximab, which helped for a very minimal amount of time, and also received cyclophosphamide. And then we started the mycophenolate. You can see where his platelet count increased significantly. And then after a time, we tapered off, and you can see his platelet count remained, and it does remain greater than 300,000. We don't have a lot of reported data on cases like the one I just presented to you. In this report by Taylor and colleagues, the patients that are reported generally have very severe disease. They've been treated with several different therapies. You can see here, some of them had secondary ITP that was due to other autoimmune diseases or had HIV. And in this case report, about half of the patients had some response. In my experience, about 2/3 to 3/4 of patients have had some response, but I don't think we've done a carefully enough controlled study of this, although we are going back and doing a more careful look at this to get a better sense of how well patients are actually doing on treatment. The FLIGHT trial, which was reported last year, was different from most reports in that it was the first one where patients had acute ITP, this being the first therapy they got when they presented to their physician and needed treatment, and also that it was randomized, although not blinded. The patients were randomized to receive steroid therapy alone or steroid therapy with MMF. The steroids were tapered after about 6 to 8 weeks. The MMF, if they were on that arm, continued for about 6 months and could be tapered if the platelet count was greater than 100,000 at that point. And the primary endpoint was the time to treatment failure, so when the platelet count was less than 30,000 or if they never increased above 30,000. There's no question that more patients who received mycophenolate responded within the first 2 months. Those are in the blue areas. And they continued to respond up to 2 years later, although those numbers tend to get very small. There, importantly, though, was no difference between the two groups in the occurrence of bleeding, rescue treatment, or treatment side effects, including infections. And also, I think of note, many of the patients continued treatment with MMF as their platelet counts were not greater than 100,000 and therefore weren't eligible to taper or stop it. The other thing that's very important here is that the patients in the MMF group reported worse quality of life outcomes regarding their physical function and fatigue than those that were getting steroids alone. So a lot of this was due to the GI side effects, but they had more fatigue. They just overall felt worse. All of the potential mechanisms in ITP can be responsible in a greater or lesser way in how severe the disease is. And any of one of these are a potential target for therapy. And indeed, we sometimes need to combine therapies as they work better than either does separately. So we might want to combine steroids with a TPO receptor agonist or with a T-cell inhibitor. The list of patients who are considered to be at increased risk of developing severe complications of COVID-19, either due to lack of response to the vaccine, for example, after rituximab, or who might have decreased responsiveness to the vaccine or an inability to fight the infection, such as people on high dose or prolonged steroids, or patients who have had a splenectomy, all are considered to be at increased risk. And MMF would be included in this category, immunosuppressive agents. I'd also add that some patients with ITP also have an inherited immunodeficiency and therefore may also be at an increased risk. And so recommendations for combined monoclonal antibody Evusheld include all of these categories. Considering our ability to raise the platelet count with relatively few and uncommon side effects, either with a short course of steroids or IVIG if it's acute, or with a TPO receptor agonist, and especially at a time of great concern around new variants of SARS-CoV-2, in my opinion, MMF should be reserved for patients with severe disease who are refractory to a TPO receptor agonist alone, or who cannot tolerate one, or who doesn't respond to one with an addition of a small amount of steroids. I've used MMF successfully in lots of patients. Most of them have tolerated it well, but I think we need to learn more about how best to use it in ITP. And I'm hoping to see more clinical trials so we can learn more about it. And with that, I'd like to thank you for your attention and wish you all good safety and health.